Hello, and welcome to the DeSera Clinical Education Oncology podcast. Today's episode features three expert GI medical oncologists: Dr. Paul Oberstein out of NYU Langone Health, Dr. Efrat Dotan out of Penn Medicine, and Dr. Andrew Ko from the University of California, San Francisco. In this episode, our faculty discuss the current treatment landscape for pancreatic cancer, including the growing role of comprehensive molecular testing, the emergence of tumor treating fields for locally advanced disease, and the latest advances in KRAS-targeted therapy, with a special focus on daraxonrasib and the practical implications of the new data presented at ASCO 2026. This episode is part of a larger educational program titled The Art of Therapeutic Balance: Innovations in Pancreatic Cancer Care Across the Disease Continuum. For more information about our faculty, and to access the full educational program, please visit the show notes for this episode. With that, I will hand this over to Drs. Oberstein, Dotan, and Co. Thank you all for joining us today for this important discussion.
Hello, everyone. Welcome to this podcast where I'm joined by two really great colleagues for an encore presentation of discussion about pancreatic cancer. My name is Paul Oberstein. I'm an associate professor of medicine and a GI medical oncologist at NYU Langone in New York. And I'm joined today by two colleagues to talk about some of the really exciting and innovative findings that have come out after ASCO in 2026.
Hi, everyone. My name is Andrew Ko. I'm a professor of medicine at the University of California, San Francisco, also a GI medical oncologist. Happy to be here.
And I'm Efrat Dotan. I'm a professor of medicine at the University of Pennsylvania and also a GI medical oncologist. And I'm excited to talk about pancreas cancer for the next 30 minutes.
Great. So before we dig into some of the really exciting new data, I think it's really important to start off, talk a little bit about where we currently are. Pancreatic cancer is one of the most common causes of death from cancer in the United States. And the current standard of care for metastatic patients really involves multi-agent chemotherapy, which can prolong survival and help patients, but is of course limited in its scope. I think, as of today, I'm curious from the two of you, anything that you would say from a standard of care that we need to remind people of before we launch into some of the new things?
Yeah, I'll start by saying that I agree. Chemotherapy does remain the mainstay of treatment, and we're quite familiar with using either a FOLFIRINOX or its sort of adjacent regimen, NALIRIFOX versus gemcitabine, nab-paclitaxel. And there's been long discussions about how to select. Right now, it's primarily on a clinical basis, although there might be some molecular features that might steer us one way or another. I think we're all excited about the possibility that chemo may ultimately be supplanted or certainly complemented by some of the novel targeted therapies that came out of ASCO and that soon will shape our practice.
Yeah, I would also want to add that I think we have all gained a lot of experience with, how to use these regimens, how to support patients, understanding how to manage toxicities, adjust therapies based on, risk of and potential side effects. So, despite all the excitement, I think we've come a long way with using chemotherapies and knowing how to maximize the benefit out of them. And I don't think that we are going to give up on them completely yet.
Yeah, I agree. I mean, I think one of the disappointing thing about chemotherapy is that for most people, it provides benefit for a short period of time and usually measured in months. But I do think for those months, for most people, we often get significant benefit, right? So patients get pain control often with chemo, often even functional status improves for a brief period of time. And so, certainly for some people who need symptomatic relief, chemo has a huge role. It's just that it doesn't really last that long for most people. One of the big things that we're going to talk about is how do we get things that are more persistent. And Fred, I guess while we're talking about symptom control as well, I think you have some insight into another novel therapy that might help with symptom control in locally advanced pancreas cancer. Tell us a little bit.
Yeah, I think it's important to remember we keep talking about metastatic disease, which is the bulk of our patients, but locally advanced disease are pretty not rare. I mean, we see them more and more. These are difficult tumors to manage. difficult to keep patients on chemotherapy for a long time. These patients suffer from significant pain and discomfort. And we do have a new device that has been approved by the FDA, which is called Tumor Treating Fields, and was shown to be beneficial by the PANOVA-3 trial. And the trial randomized patient to receive this tumor treating field radiation device along with chemotherapy, and was able to show significant improvement in pain-free survival. And since this causes significant burden for patient, I think we should consider these treatments for the appropriate candidates.
Great. Thanks for sharing. I think before we get into, our discussion about KRAS and what we call the KRAS revolution, so KRAS is, of course, a gene alteration or mutation. And I'm curious of everyone's practice. In my clinic, we refer every new pancreas cancer patient for both germline testing and tumor somatic testing. Often we don't have enough tissue to really do robust testing, and we send blood. I'm curious to hear your practices and what you think is really important to be done for metastatic patients.
Yeah, so I'm definitely doing the same, Paul, in terms of germline testing, regardless of family history, and now somatic testing, ideally on tumor biopsy specimen. And both our interventional radiologists and gastroenterologists who are doing the endoscopic ultrasound guided tissue sampling understand now that getting a core biopsy as opposed to just an FNA is important in terms of adequate yield for doing next generation sequencing. And the good things I'm seeing out in the community, I think there's increasing awareness that this should be done. Now, in the past, I would tell patients, well, it's always great to get this information, but that information is not always going to be actionable in terms of finding therapeutically relevant targets. And the nice thing as we move into the RAS era is that identifying not just the presence of a RAS mutation, but the specific genotype is going to be very informative in terms of guiding our clinical practice. And so in the past, it was like, well, that should be done maybe down the road at some point after patients already gone through chemotherapy and are looking for other options. But now I just really want to impress that this should be done at the time of original diagnosis. Get those results really early on to help shape your treatment plan for patients.
Yeah, I would take that even further. I wouldn't wait till patients are metastatic. Patients were resected or have enough tissue at diagnosis, I would get in upfront. We are going to have more and more opportunities to use these targeted agents in the adjuvant setting or neoadjuvant setting. So the earlier, the better. I also, I'm really impressed. I remember when I started to send up blood years ago, and there were all these papers that there is not enough shedding of the pancreatic tumor into the blood, and we would never be able to detect cells. These assays that are available now are so sensitive that even if the tissue is not sufficient, which is a problem we run into often, I quite often am able to get some data from peripheral blood, at least in terms if the patient has a KRAS mutation, and often they can tell which one. So yes, you really need to work hard to get the NGS testing. And I would add one more thing. I think we'll talk about it a little bit towards the end of the podcast, but if you get NGS testing and you do not find a RAS mutation in pancreas cancer, that should be a big red flag in your mind to go and dig deeper, because there has to be something else driving this tumor. And is it that we're not seeing the RAS mutation because there was not enough in that sample? You took blood and they weren't able to isolate enough cancer cells, or is it because the patient really has some other mechanism that drives the cancer? So don't stop there.
Don't stop. I think that's really important. I agree. And yeah, we do the same thing. I mean, I think when we don't see a RAS mutation, we always ask, did you see a different driver? Right? If you see another driver, that explains it, NTRK or BRAF. But, sometimes it's just not a sensitive enough test, right? But I guess, it's a great segue into our next, segment, which is really, I'll call it the elephant in the room, but the RAS in the room. 90 to 95% of patients will have KRAS mutations in pancreas cancer. This is not news. We've known this for quite some time and been trying to target it. And we're about to hear a summary of some great data. I guess before we get there, like philosophically or big picture, why do we think we suddenly are more successful and have the first real pan-RAS inhibitor?
In terms of understanding the structure of the molecule, identifying a hidden pocket, the so-called switch II pocket that formed the basis for the original inhibitor, specifically for KRAS G12C mutations, which definitely have a role in especially in non-small cell lung cancer, but just isn't seen that commonly in pancreas cancer. But we sort of moved away from this idea of, oh, well, this is something that can't be targeted in the past because of, well, the thought that this has a very smooth surface, right? It doesn't have a lot of deep binding pockets, and it's kind of toggling between an on and off state. And just even at the nucleotide binding site, there's just such a tight affinity for GTP that it was hard to develop competitive small molecule inhibitors for. So with the development of daraxonrasib, this pan-RAS inhibitor, which inhibits RAS in its on state, which is mostly where RAS resides, toggling between on and off, daraxonrasib binds to this chaperone protein called cyclophilin A, which then forms this tri-complex inhibitor with RAS, thereby preventing binding to downstream effectors like RAF. And so it essentially shuts off RAS signaling, which is really responsible for the great clinical results. So aside from the terrific clinical results, I think the excitement is just because this has been sort of the holy grail in pancreas biology and developing novel drugs targeting this specific pathway. And I'm just really excited that we're finally there.
Yeah, I guess maybe Efrat, you can comment on this. I also think it's amazing how, what you just described, Andrew, that it's a new mechanism, right? They found a new way essentially to have this molecule be targeted. But it's also true that, direct RAS inhibitors and the off inhibitors are making progress as well, right? And we saw even at ASCO other drugs. So all of a sudden, it seems like we're finding potentially multiple ways to drug what's been undruggable. And it's sort of like the floodgates have opened, and I don't actually know if it's a switch or we're just trying more and more things. But our hope is that we'll see many more inhibitors, not just one pathway, but many ways to block RAS.
It feels like the floodgates have opened for many, many targets. And there are multiple targets that I don't think any of us have thought about as options for pancreas cancer that are now becoming options, including Claudin and MTAP. I think we really are in an era of better understanding of the biology, better understanding of the mutations that are driving these tumors, and going into a highly personalized treatment approach for these patients.
Andrew, maybe you could summarize for us or share your impressions of the daraxonrasib data from the RASolute 302. We know there was a standing ovation. I was in the room, which was exciting.
Yeah. Yeah, I mean, I think a lot of us who have been devoting large parts of our careers on research and caring for patients actually got kind of emotional seeing those Kaplan-Meier survival curves pop up on the screen. The phase 1 data that already looked really promising, I was thinking, oh, well, if the phase 3 trial can even anywhere near replicate those kinds of results, it's going to be a home run. I was almost going to be disappointed if, well, it's, the phase 3 study was positive, but maybe the results weren't quite as transformative as sort of the early data would suggest. But this study, which was a big phase 3 study, and again, specifically in the second line setting. So this was for patients with metastatic disease, had previously received one line of chemotherapy, and were now randomized either to get sort of standard second line chemotherapy, depending on whether they started with a GEM or fluoropyrimidine-based regimen. So they were randomized to either get standard of care chemotherapy in that second line setting or daraxonrasib. 300 milligrams daily. So the primary endpoint specifically focused on the majority of patients who had mutations in codon 12. But then they also showed the data for all comers, including those with mutations at other spots in the RAS gene, and some even who did not have a RAS mutation. So if you look at the overall survival results for the primary endpoint, overall survival for that G12 population, you saw a hazard ratio for survival of 0.40. We rarely see anything like that in pancreas cancer studies. This was just a really terrific magnitude of benefit with daraxonrasib compared to chemotherapy. And I'll say chemotherapy matched what we see historically, a median survival of about 6.5 months or so. That's what all prior studies had shown. Whereas folks getting daraxonrasib had a median survival of upwards of 13 months. So it's 13.2 versus 6.6 months. And then even the secondary endpoint, looking at the overall population, kind of irrespective of what type of RAS mutation, also basically matched that with hazard ratio of 0.40. And then there were improvements in all the other relevant clinical endpoints that we typically look at for these types of studies. Progression-free survival was better. Objective response rate was better. This is clearly something that once it gets approved, and well, as all of us know who are trying to get this early access program available for our patients, this is going to completely change the way we treat patients, starting in the second-line setting, but I can only imagine that we're going to be looking at it. We're going to be using this in earlier line settings and in earlier stage disease, probably sooner rather than later.
I have to echo what Andrew was saying, that listening to that presentation in the room and experiencing that standing ovation was probably the most emotional event in my whole career. And I'm sure you guys agree. It was just, I saw images of the many, many, many pancreatic cancer patients that I've had over my career who could have benefited from this. And I think this is just such a advancement to the field and just the beginning. As Andrew said, this is, really opening up such hope for our patients. So it's just amazing.
I agree. That room was incredible. And I think not, I mean, like you said, for patients, but I think I was thinking of all the people who've done trials, who've plugged at it and designed these, it's just an incredible achievement. To me, I mean, Andrew, you mentioned the hazard ratio. I think what was so incredible was that it wasn't so selected, right? Meaning we've seen some very narrow trials where you take a subset of patients and you target them and you're like, we can get very good efficacy in those patients. But here it was essentially all patients, right? And those hazard ratios and that benefit was seen both in the primary cohort of G12 mutated patients, but also all comers. And it was just amazing that this is something that might be relevant for everybody. Curious, I think, what have you thought since then, right? It's been 3 weeks since we saw that presentation. A lot of questions have come up. Everyone's trying to ask what happens next. And I think one of the biggest questions is, what's next in terms of therapy, in terms of who becomes resistant to daraxonrasib, right? And can we identify them and what do we do next? I think, any thoughts on that?
Yeah, I mean, before we go there, which is a great question, Paul, I think this is going to beg the question, since it seems to be effective almost irrespective of RAS mutation as well. Do you actually need to do testing? Do you need to ascertain the RAS mutational status before actually giving daraxonrasib if it really is effective, even in potentially in RAS wild type or in non-G12 patients? I feel pretty strongly, and I think you guys would agree, that actually doing the testing, and Efrat, you'll probably do a little bit deeper dive into talking, or you already mentioned some of the other targets there. I still think it's going to be really important for us to do that next-gen sequencing on patients, in part because, as folks have alluded to, there are some allele-specific KRAS inhibitors coming down the pike, including, and particularly for G12D, which is the most common mutation seen in pancreas cancer. And it may have some advantages, especially in terms of toxicity compared to the pan-RAS inhibitors. So I do think that doing that testing is important, and probably doing testing at the point when patients do develop resistance, which hopefully is pushed way down the road. But just because it looks like there are many different mechanisms that may explain the eventual development of resistance to RAS mutations. Some of them are genetic, and some of them may even be completely non-genetic and just sort of histologic transformation possibly, or sometimes there might be just upregulation of MAP kinase signaling, or even possibly HER2 overexpression, or any number of potential resistance mechanisms. So I think the NGS testing up front, and then ideally at the point of developing resistance, because that may then inform later lines of treatment in terms of targeted therapies.
Yeah, I think the question is going to become even more complicated because we're going to have all these newer inhibitors coming through. G12D specific inhibitor, for example, would you use that first and then use a pan-RAS? Would you use that after? How would we sequence these therapies? Would you combine them? What about other targets? I mean, I think we're going to be in a situation where we're just going to really have to understand resistant mechanism and what actually happens in the protein level to guide how we're, sequencing the treatments per se. So
Yeah, or even Efrat, like you mentioned, MTAP loss, which
yeah,
is not uncommon. You see that in maybe 20, 30% of
10%.
pancreas cancer. So there are studies that are looking at combining RAS inhibitors with PRMT5 inhibitors. So whether it makes sense to combine them up front, whether it makes sense to do them in sequence. So there's a lot of interesting directions to be able to go in terms of sequencing and combination strategies.
And chemo, right? So we don't
And
know.
yeah, chemo too.
So there are ongoing studies with chemo, obviously, sequencing questions. Earlier, as you said, there's this adjuvant study, right, of maintenance daraxonrasib after chemo. So really, I'd say a ton of studies, but also really a lot of these questions that might help us understand resistance. One last question on daraxonrasib. Our hope, of course, is that this will rapidly be approved. We don't exactly know what the approval will say, but everyone's eager to get this drug, everyone with pancreas cancer, and hopefully will soon. There were toxicities seen with the drug. It's definitely a new drug. It's something that we haven't quite targeted before for most patients. And rash was the big and very noticeable toxicity, though there were other ones. I guess question is, what do we think, or any thoughts on what's going to happen when this starts getting adopted very broadly in community centers and places where they don't have prior experience, and how we can manage some of that side effects?
Yeah, I think the training is going to be important because, there's perhaps some overlap with, for example, EGFR-associated rash, but it's not quite identical. So that stomatitis, diarrhea, those are the three sort of most common side effects. And in cases where it's refractory, it is very important to be friends with your local dermatologist because there's some additional tricks that are sort of beyond the scope or knowledge of us non-dermatologists. So I do think, thankfully, for the most part, the rash is manageable. And because of the short half-life of the drug, if you hold the drug for just, say, up to a week, those types of side effects generally subside to the point where you can restart drug, whether at same dose or perhaps at a slightly lower dose. But, there are parts of the country, parts of the world where you don't have good access to a dermatologist. And so I think really it's the education piece and you sort of what to expect. So people aren't thrown a curveball and sort of shy away from using daraxonrasib at the first sign of sort of a grade 3 rash.
Yeah, I think patients with pancreas cancer are willing to endure a lot of things, but it is our job to make sure that we proactively manage that symptoms and keep them on the drug.
Curious if either of you have thought of other things besides KRAS, besides the one, you mentioned Andrew and Efrat as well, MTAP deletion, which I do think is a big target. I mean, it's almost a third, 20, 30% of patients. And there are really cool drugs coming out for that. So I'm excited to see where that goes, both in combination and alone. Anything else that stuck out or jumped out from the conference?
Well, I think, as I said earlier, RAS wild type, we have to look for a target. So, and there were studies showing that in these RAS wild type, albeit very small percentage of patients, you can find NTRK fusions, you can find BRAF mutations, you can find NRG1 fusions, RET fusions, and all of these targets have specific treatments that are all FDA approved and could really benefit the patient. And then the other target is Claudin, which is becoming more and more studied in various ways, whether it's through antibody like zolbetuximab. There are studies involving CAR T targeting Claudin, bispecific antibodies, ADCs, and MTAP, you mentioned, in about 20 to 30% of patients using the PRMT5 inhibitors. And there are multiple ongoing trials comparing chemo alone to chemotherapy plus these inhibitors, with some preliminary data showing very good response rates. So I think, what our audience should take away is that there are going to be a lot of new advances in pancreas cancer, but let's encourage patients to go on studies, to participate in these trials, especially if you find a very unique target, and help us get the data faster so we can get these drugs out to patients faster.
Yeah, I've had my first couple patients fraught with NRG1 fusions, which are very rare. But since we have now
Yeah.
zenocutuzumab and by
Exactly.
specifically targeting this, it's actually a well-tolerated and quite effective drug for that very small subgroup of patients. And just to your point, for those KRAS wild-type tumors, some of these alterations are really better picked up by RNA sequencing than DNA. So thankfully, a lot of the commercial platforms give you that option. So be sure to do RNA sequencing for patients if you're not picking up a KRAS mutation.
Great. I just want to mention, we keep saying there's new information coming, obviously a new therapy and toxicity and managing the rash. I want to give a shout out to PanCan, who have this, Pancreatic Cancer Action Network, have a great patient services phone number they have. It's a website. They've got all kinds of resources. And certainly there are many others like that are there to help our patients navigate this new landscape. I think just to close it up with one question, I'm not sure what question, but I guess, what do you, either of you, both of you, I guess, what do you think is going to look different in your practice in 12 months because of this data that's coming out?
Okay, I've thought about this. And so for sure, let's say daraxonrasib gets its approval, well, hopefully as soon as possible. I'm going to initially use it sort of as it's specifically approved, meaning after folks have received chemotherapy. Now, I think there's going to be a lot of end arounds and people are going to have come up with excuses to stop patients short on chemotherapy just so that they can switch over to daraxonrasib. And I understand that. I guess maybe I'm a bit of a purist and would want folks to sort of max out on their benefit or tolerability of chemotherapy before shifting gears to daraxonrasib. There are first-line studies that will accrue very rapidly and will give us that answer in terms of, for frontline treatment, can daraxonrasib as a monotherapy, is it going to be as good or better than chemo? Is combining chemo with daraxonrasib going to be the way to go? And again, there are other chemo plus other RAS inhibitor studies going on. So I'm not quite ready to say we're going to give this to upfront patients. I don't think that's what we should be doing until we have a little more data in that frontline setting to inform that decision. But there's no question that ideally every patient at some point during their disease journey will be able to receive a RAS inhibitor. I think that will be probably the wholesale change that I anticipate adopting.
I agree with Andrew 100%. I think that the main thing that's going to change is that my clinic or my patient panel is going to grow even more, because I think our patients are going to live longer, enjoy life, not getting chemo. It's a dream. So I guess, I don't know, maybe I should recruit another GI oncologist.
Yeah, I that's the message. I mean, it's a good message. We're going to get busier.
Exactly.
We need more oncologists. So
yes, but our management of these patients is going to be different than that, because they're different side effects than chemotherapy. So, and it might be less frequent visits, but learning how to manage rash and these other things, I'd say a good problem.
With dermatology and it's great problems to have.
Thank you, Drs. Oberstein, Dotan, and Co. And many thanks to you, our listeners, for joining us. As a reminder, to view the full program, The Art of Therapeutic Balance, Innovations in Pancreatic Cancer Across the Disease Continuum, please click the link in the show notes. And be sure to check back regularly for more episodes on important oncology topics.